Hello, I'm Dr. Ken Landau. Thanks for watching. Let's talk about Xiaflex, and let's talk about it specifically with regard to treatment of Dupuytren's contracture. That's a hand disease that causes the fourth and the fifth fingers not to be able to be straightened out. The drug was originally approved in 2010 for one site in one hand at one time. But by 2014, enough experience was gained with the medicine, so the FDA allowed 2 injections at the same time in the same hand. The drug also was approved, by the way, for treatment of a relatively similar condition of the penis. When the penis becomes erect, sometimes it's curved. That's called Peyronie's disease. The same medicine is used to treat Peyronie's disease. But going back to Dupuytren's contracture, what happens is the palm of the hand has a fascia underneath the surface of the skin, and on top of the muscles and the tendons and the ligaments and the nerves, it allows the contents of the hand to glide freely without getting stuck on the hand surface. Now, what happens in Dupuytren's contracture is this fascia underneath the surface of the skin becomes thick, and it becomes thick under the fifth and under the fourth fingers, and it draws them in so the fingers can't be extended. There are thick and shortened bands of fibrous tissue. Sometimes they're just little bits of fibers from that thick fascia that come up to the surface of the skin and pull down, causing pits and grooves. The disease tends to be most prominent at the MP joint, the metacarpophalangeal joint, that's right here, and at the proximal interphalangeal joint, we call it the PIP joint, the MP and the PIP joint. And when you have enough of the contracture, you can't open the hand for the fourth and the fifth fingers. Now, it often starts with a nodule on the palm, and sometimes the nodule leads to more extensive disease, and then what we call the flexure contracture, and then a decreased range of motion of the hands. There are about 200,000 cases that occur each year. It was originally thought to be a Viking disease because about 30 or 40% of the people in Norway seem to have it. But the more we study the condition, it seems to be all over Europe, from Bosnia down to Belgium, and very high incidence. It happens in men much more than it happens in women, in whites, 5 times more often than in blacks. Half of the time it's bilateral on both hands, and the incidence in the United States is somewhere overall in the Caucasian population, about 3 to 6%, with the range in Western countries varying from as low as 1% to as high as 32%, depending on how carefully one looks. The name of the condition is after Baron Dupuytren, who was a French surgeon in the early 1800s. He defined it correctly as a disease of the fascia, not of the tendons. But on careful evaluation, it actually was originally described in the early 1600s, but largely forgotten. Well, Dupuytren's contracture, obviously, if you can't extend your fourth and your fifth fingers, it's hard to wear a wedding ring, play a piano, it's hard to put your hands in your pocket or wear gloves, or if you're a woman, knit or hold a bottle or caress your spouse or clap your hands. And sometimes when you wash your face, you can actually poke your eye. Well, Dupuytren's contracture involves this fascia of the palm that's made of collagen, connective tissue. It's a sheet-like material. And in this condition, the fascia becomes extra thick, and then it becomes hardened, just as it is in a scar tissue, and then it can adhere to the skin or the tendons or the arteries or the nerves, and that obviously is a problem. It can start off sometimes as a nodule, as I mentioned, sometimes has those pits and grooves. Early on, it seems to be painful, but not later on. The pain seems to go away. There are 3 clinical phases of the condition. First is the proliferative phase, where we get the fibroplasia, and then we get contraction of the myofibroblasts. That's the second phase, the contractile phase. And then ultimately, it's replaced with connective tissue and we get the scarring. Why people develop the condition, we haven't the slightest idea. It seems to frequently be associated with people who could get a frozen shoulder or a carpal tunnel syndrome or a thickening of the plantar fascia, the fascia that's also on the foot. It's thought to be probably the result of some micro trauma or trauma that occurs. Maybe it's in the course of hard labor with the hands or vibrations. It used to be thought that it had something to do with alcohol and people who drink too much. Then it was thought to be related to epilepsy, and it's probably not related to epilepsy, but it might be related, at least in some cases, to treatment with phenobarbital or dilantin, phenytoin we now call it. Sometimes seems to have a higher incidence in older individuals, obviously, and in people who smoke cigarettes, thought to be genetic or hereditary in a fair number of people, and then sporadic on an awful lot of individuals. And it sometimes seems to be associated with what we call Garrett's nodules. These are nodules that occur on the back of the hand, not just on the skin surface, like a callus, but actually underneath the surface. Those people seem to be at risk for Dupuytren's contracture. Now, it is not apparently related in significant incidence with Peyronie's disease, but it is with that plantar fibromatosis on the bottom of the foot, basically the same thing as on the palm. We call it Lederhosen disease. Why does the collagen form? Well, there are a couple ideas about it. Maybe it started off with some ischemia and free radical formation, but now we think it probably has to do with a disorder of the extracellular matrix, not the cell itself, but the stuff the cell sits in, and then some mechanical trauma that occurs that sets off a whole bunch of production of cytokines and other kind of inflammatory peptides, and then it ends up as this kind of condition. Now the question is, how is it treated? Well, it's treated with the Xiaflex. And the Xiaflex is an injection, and a third of the medicine is injected into the area where the thickness is greatest. The needle is withdrawn. It's placed a little bit further down the skin, injected another third, and then a little bit more closely to the palm, inject another third. So there are 3 injections that occur. The hand is then wrapped in gauze. Instructions: keep the hand elevated until bedtime. Don't do anything severe or significant with your hand, and then go to bed. And then you come back to the office the next day or the second day or the third day, and then the doctor performs what is known as a finger extension. So after the injection, theoretically the collagen becomes soft, and the doctor, with or without local anesthetic, the injections are not with anesthetic, but now when the fingers are moved and extended, sometimes people need some injectable anesthesia, some Novocaine, xylocaine, and then what happens afterward is sometimes it doesn't work. And we can repeat that extension 3 times, leaving about 5 or 10 minutes in between. Sometimes we hear a loud pop. Then what happens is the patient wears a splint over the area, wears that splint every night when they go to bed, keeps it on for about 4 months. Patient performs in the daytime those extensive exercises, moving the fingers out, moving the fingers out. And then sometimes what happens, especially when it first occurs in the doctor's office when you first return, sometimes actually the skin splits open and there's significant bleeding. And standard wound care seems to be quite sufficient. So the end point is when there's no contracture left, or the skin goes to just about 0 to 5 degree abnormality. That's considered, about 30 days after the last injection, quite sufficient. That is how we define success. It occurs in 65% about of instances. If we're talking about the MP joint right here, 65% success. If we're talking about the PIP, the proximal interphalangeal joint, the likelihood of success is only about 30 or 40%. So if we look after the first injection, well, we're successful maybe 30–40% of the time. But after the third injection, then that's when we see the overall marked improvement. Well, the injections occur as close to the palmar crease as possible, especially when we're talking about the fifth finger. And we want to inject not where the skin is markedly adherent. The injections are very superficial. It's only about 2 or 3 millimeters, sort of the thickness of a dime or 2 dimes put together, not injecting into the tendon. If the hand is injected, and it's going to be injected twice, not in the same location, not in the same area. We tend to begin on the fifth finger and then go to the fourth finger. We tend to start with the therapy closest to the MP joint and then go to the PIP joint. As I mentioned, no local anesthetic for the injections themselves. We use a relatively small needle. And then we have to adapt the therapy for the severity of the condition. So if we have a thin cord, that's one thing. On the other hand, if we have a thick contracture, log-like area, then we're a little bit more aggressive. Well, within a week of the therapy, you should not receive any blood thinners. So warfarin is out, Eliquis is out, Pradaxa, Xarelto, all of those kinds of medicines are out. Even aspirin at a dose of 150 milligrams or more is out, as are the non-steroidal anti-inflammatory drugs, drugs like ibuprofen or naproxen or Aleve, Advil. Now, collagen is the main tissue in the skin and the tendons and the ligaments, so it's very important where the injections are placed. It's not at random. It's very careful, done by an experienced physician. The medicine itself is a combination of 2 collagenases. Collagenase means something that's going to dissolve collagen, and we already said that the scar tissue that forms is collagen. Well, these collagenases are made in the bacteria. Actually, it's the bacteria responsible for gangrene. And we have the 2 different kind of collagenase, and they tend to attack collagen type 1 and collagen type 3. There's a little bit of collagen type 4 around the blood vessels, but that's not a major issue, at least when we're talking about this kind of therapy. Now, one of the collagenases starts off digesting either end of the collagen fibril. It's like a string of hair. And the other collagenase starts chopping up the middle. And then when we get the protective elements off of the collagen fibril, then both of them seem to just chop it up at will. It's important to realize that multiple injections are going to be needed and multiple sites are going to have to be injected. The average person gets about 3 different sites injected, and a lot of these people have already had surgery and they failed the surgery, and now they end up getting the therapy. The average is 1.5 or 2 injections is sort of the standard. The angle when the person comes in is anywhere between about 20% and 80% or even 100%. The fingers can be bent. And they have what we call a positive table test. They can't lay the entire finger and the palm on the table at the same time. The medicine comes as a powder with a diluent, a solution that we have to inject into the bottle where the powder is. It's mixed. The patient's injected. Patient comes back 24 to 72 hours for that extension that we talked about. We can inject an area 3 times at 4-week intervals. So you can come back the first treatment, come back the second treatment, come back another kind of a treatment. Now, it's important that there is more fluid in the solution and more medicine present in the powder than we use. There are certain ways to dilute the medicine, and there's a certain amount that is drawn out for injection. The unopened bottles are kept in the refrigerator. They are taken out of the refrigerator about 15, 20, 30 minutes, an hour before the injection. If the medicine's at room temperature, can be kept at room temperature for up to about an hour before use, or can be kept after mixing, can be kept in the refrigerator for about 4 hours. If you're treated with the injection, you can return to work pretty promptly, but if you have the surgery, you may well have a month before you can get back to performing your regular daytime activities. Now, the question is, does the disease recur? And the answer is yes, and after about 2 to 5 years, about 50% of the people seem to have at least a 20% recurrence of that contracture. So about a 20% contracture reoccurs. That's in the patients who are followed. There are a significant number of patients who are lost to follow-up. So the results might not even be as good as we think. The people who tend to get more recurrences are males, tend to be younger males, less than age 50, people with bilateral disease, people who have involvement of the thumb or more than 2 fingers involved, or people who have the ectopic disease, have that Garrett's problem that we talked about, the Garrett's fascia, or have the Lederhosen disease on the foot, or people who have a family history. Are there any kind of side effects of the therapy? And the answer, of course, is yes. There's significant swelling of the area, swelling of the hand in more than 70% of the people. Contusion, looks like you've been in a battle in about 70% of the people. Hemorrhage at the site, anywhere between 50 and 70% of the people. Pain at the site in about a third of the individuals. And then some people get allergic reactions, starting with itching. And some people even get swollen lymph nodes. Unfortunately, if the injection isn't quite right, you can have a tendon rupture. You can have significant pain and vascular injury. We call that the complex regional pain syndrome. And as I mentioned before, the skin may tear. And if it's not injected correctly, you can get a tendon rupture. You got to be very careful, or the doctor has to be very careful, to inject the right spot and not the tendon, not the nerve, not the blood vessel. All of those things can be significantly damaged. Well, when the medicine came out, the Food and Drug Administration mandated a follow-up, and it's called a risk evaluation and mitigation strategy. And what they said is, we want to know what happens to the people after you inject them. We want to know the follow-up. We want to know if there are any kind of problems. And you, the prescriber, you, the doctor, have to be certified. You have to enroll in a program and at least watch some other doctor who's experienced inject before you go and do it. And so far, since the medicine's been approved, the Food and Drug Administration has received at least 570 reports of significant injury, including 20 deaths associated with the medicine. Now, that does not mean that there's cause and effect. That doesn't mean that the medicine was responsible for the 20 deaths, but they were reported to the Food and Drug Administration, and that's probably the tip of the iceberg, because most people who have injuries are not reported. Now, the company is suggesting that we don't have to wait until the person gets the significant contracture of the 4th and 5th fingers. Maybe just when a nodule is present, maybe that would be sufficient enough to inject. So now the company is trying to perform experiments to see if that might be something that the Food and Drug Administration would buy into. And so far, they've performed some studies, have some follow-up with just one injection, and the people seem to be happy 80–90% of the time. However, we don't know that those nodules are going to progress to any kind of a problem, so we might be treating people who don't need any kind of therapy at all. There are other options available, something very simple called a needle fasciotomy or a needle aponeurectomy, where a hypodermic needle is just inserted into the area and pushed in and out, in and out, in and out, and that seems to disrupt some of the connective tissue, and then under local anesthetic, of course. And then, afterward, we can have aggressive exercise of the area. And actually, this treatment that was devised in the 1970s by some French rheumatologists seems to work pretty well. Don't need any hospital, don't need any special facility. It's in-office procedure, of course. There's surgery that's possible, and the surgery tends to be more intensive, more invasive, of course, and has a lot more side effects. Well, they're trying to see if Xiaflex might have a role in treating lipomas and cellulite and frozen shoulder. It's being used experimentally in a lot of conditions. Question is, will it fly? Don't know the answer to that. Suspect not. The drug was originally developed by a small chemical company, pharmaceutical company, technology company in suburban New York. It's called Biospecifics Technology. And they licensed the medicine to another pharmacology company or a pharmaceutical company. The first treatment was as an ointment. It was a collagenase ointment that was applied to wounds, but that was never very popular. Then it was used to treat herniated discs as an injection. And then in the 1990s, a couple orthopedic surgeons in suburban New York, at the State University of New York, they got the idea, well, maybe this would work for Dupuytren's contracture, and that's how the whole story began. Well, the company that was manufacturing it was bought by Endo International of Dublin, Ireland. And they paid about $2.5 billion for this company. And the CEO of Endo happened to come from Valiant Pharmaceuticals. Valiant Pharmaceuticals has an awful lot of baggage. They have some perhaps unethical activities and some very peculiar financial activities. And it seems like maybe some of those activities were brought over to Endo, because now in an article in Bloomberg from January of 2018, the article says that basically everything that could go wrong with a drug company went wrong for this drug company. They have a debt in excess of $8 billion, enormous number of lawsuits, regulatory challenges to their medicine. For instance, they made an opioid. The FDA told them to take it off the market. Now, the company is facing more than 125 different lawsuits by state attorneys generals, by counties, municipalities, and now it seems the federal government wants to get into the act and sue the companies. The estimated liability is anywhere between $5 billion and $50 billion, and the governments have hired some of the same lawyers that were responsible in the 1990s for the tobacco litigation that was settled for about $250 billion. Endo also seems to be involved in the vaginal mesh debacle. They had more than 46,000 lawsuits. They were settled for about $3.5 billion, and now the company's engaged in lawsuits from at least 1,300 patients over their testosterone gel and claims that these men had heart attacks. But the good news, if there is any good news, is if you happen to be prescribed this medicine, if the doctor tells you to get it or the doctor provides it, well, you have the potential to get a copay card to reduce the out-of-pocket expenses. And you can reduce the out-of-pocket expenses by $1,200 a treatment. So you can be sure that this is going to be an expensive medicine. In September of 2015, the cost was about $3,600, and it has increased consistently and continually to a current $4,400 plus, or more than 25% increase in just a very few years. You could purchase one vial of the medicine at Costco or at Walgreens for about $4,500. The wholesale price of the medicine might be somewhere around $3,200. So yes, this is a treatment, and the treatment works fair for some men. It rarely is a home run. You have about a 50% chance of recurrence of the disease. It sure seems better than surgery, but if you were given the option of the needle aponeurectomy or the needle fasciotomy, where the pokes a couple times, the one that the French rheumatologist came up, boy, I'll tell you, that would seem to be the way to go. But this certainly is less cumbersome than surgery. Don't need hospitalization, and you can get back to work relatively quickly. But remember, the company that makes the product has an awful lot of baggage, an awful lot of lawsuits already. And now they're just starting to popularize this medicine. So if you're going to consider this medicine, proceed with caution. I'm Dr. Ken Landau.